To me, the most misused terms that really have no official definition and are not official diagnoses include ocular migraine, ophthalmic migraine, eye migraine, take your pick, complex migraine, complicated migraine, cluster migraine, and then my favorite, which is really, I'm being very sarcastic because it's one of my least favorite terms in the world, is either, take your pick, migraine cocktail or headache cocktail. And that just drives me up the wall when I hear that for various reasons.
Right, absolutely. That's a lot of confusing terms. I found a new one just recently. Someone posted about it, tension migraine as well, which
Oh, you know, somebody actually just came in my office and said that. And I was like, whoa, I hadn't heard that one. No.
Yeah. That was a new one to me as well. It's very interesting. It can be really confusing. So we're going to talk about that a little bit today, hopefully clear things up a little bit and talk about why it's important. So, but before we do that, what would you say is the difference between a primary headache disorder and secondary headache disorder? Because I know that kind of sets the scene for our other questions.
Sure. So when we talk about primary headache disorders, and I know many of you are familiar with this, we mean disorders that we cannot find another reason for. And the group of primary headache disorders includes migraine, cluster headache, and the other headaches that are in that family, hemicrania continua, hypnic headache, primary stabbing headache. And in order to make a diagnosis of a primary headache disorder, we have to make sure there's no secondary headache disorder. Secondary headache disorders just means there's a reason for it. So the patient has a brain tumor, they have had a stroke in the past, they have sinus disease, they have dental disease, there's just something else going on, right? They had head trauma that's causing their headache. So that's what we mean by secondary headache disorders.
Okay, that makes sense. Thank you for clearing that up. So bearing that in mind, why is it important that we're on the same page when it comes to terminology? What is the big deal that we all use the same terms?
It's super important. And the International Classification for Headache Disorders is kind of like our terminology handbook, if you will, that takes all of these different things and it classifies them. It gives us a diagnostic criteria and explains sort of the nuances of making the diagnosis. And it's important to have the right diagnosis, mostly because that's how we base our treatment. So if somebody comes in and they tell me they have cluster migraine or whatever, and it turns out they really do have cluster headache, that's a different story. It's treated completely differently than migraine is treated. And so in order for us to sort of figure out which way we're going to go to make people better, we really have to have a good understanding of what's wrong with them.
Right. No, that makes total sense. And I imagine that would be the same for things like tension type headache as opposed to migraine. So if you say you have tension migraine, which do you actually have, right?
Right. You know, it could be back before we had the diagnosis of chronic migraine, which largely came to pass because of Botox coming on the market for chronic migraine. So we needed a good definition of that. And that was when we sort of lumped the combination of having tension type headache and having migraine headache into one diagnosis, which we call chronic migraine. So when I hear that, it always makes me wonder if people have chronic migraine, or it's not that uncommon for people to have two different kinds of headaches. So maybe the person has tension type headaches sometimes and they have migraine sometimes.
Interesting. That kind of leads me to a question that's not really on our list of questions, but I hope you don't mind. But have you seen that terminology has changed over the past decade? And does that explain some of the confusion, or has it just always been incorrect terminology used?
A little of both. You know, so migraine, we now call it migraine with brainstem aura. We used to call it, well, like way back when, we called it basilar artery migraine because we thought it was coming from, you know, vasospasm of the arteries in the back of the brain. We now know migraine is a totally different mechanism than that. And so that kind of morphed into basilar type migraine, not actually mentioning the artery itself. And then that changed into migraine with brainstem aura. So yeah, the names, some of the names do change over time, but some of these names were never really names, like ocular migraine or, you know, complicated migraine. I mean,
Right.
What is that, right? I guess we don't know. We call it complicated. no, there probably are explanations for it, but some of these things are just terms that got thrown around and they sort of entered our lexicon and we have been unable to get rid of them.
Sure, I appreciate that. I have so many questions for you that I don't have on my list, but I'm going to try to stick to the script, but it does kind of bring us on to the next question. So you mentioned complex migraine or complicated migraine. Is that actually a diagnosis, or is it just a descriptive term about the complexity of someone who has migraine?
I think it is the latter rather than the former. The scenarios that I usually see this used in are patients who often have migraine with unusual types of aura, right? So they might not just have visual aura, they may also have trouble with their speech, or they may have loss of consciousness or double vision, or something that's just a little out of the ordinary that we would put into the classification of migraine with brainstem aura or hemiplegic migraine. And so, you know, they end up being called complex migraine, usually just by people who are not familiar with the ICHD criteria, and that's totally understandable.
Right, that makes sense. So a little side question for that. If somebody has Alice in Wonderland syndrome, that aura, I'm just throwing this into the works. Does that count as complex migraine, or is that just something completely different?
Well, that's still considered an aura of migraine, and we would just call it Alice in Wonderland syndrome.
Interesting. Yeah, I actually get that. I don't get it very often. I had a lot more when I was younger. I had no clue. I thought everybody had it. Things get very, very tiny, really far distant. And I literally thought everybody else just experienced this in their vision. I had no clue until actually about a few years ago when I realized, hey, within an hour, 2 hours after that, I get a full-blown migraine attack. And then I started looking up. But it's really curious. I'm sitting there looking at people and I'm thinking, do you realize that you look really tiny right now? And it's a bizarre thing. So
I guess, you know, some people who grew up during the 60s might have similar experiences, but
right. That's it.
In general, that's not really considered normal.
Yeah, I that's actually funny. Okay, I grew up in the 60s, but I was a little child then, so not that era. So the next question is, what are some of the diagnoses? And I know that this is a really huge thing. That's kind of going into your area of study and specialty. What are some of the diagnoses that are often missed or that are misdiagnosed as migraine?
Sure. So I'm going to actually start with cluster headache. And a lot of people think, first of all, they say like they have cluster migraines. I'm like, what's that? And we take the history and it turns out they don't have cluster headache at all. They have migraines that tend to occur frequently, one right after another. And sometimes there may be a break in between them, but the headache is clearly migraine. Cluster headache's a totally different kind of headache. But the tricky part about cluster is that people can also have what we would consider migraine symptoms with it. And so especially women with cluster headache often get misdiagnosed with migraine. Men can too. So with cluster headache, the diagnostic criteria basically say that you're going to have this horrendous headache. It's usually centered around the eye, the front of the face, maybe the ear. It comes on relatively suddenly, like it peaks in intensity within minutes to the worst pain you can ever imagine happening. Sorry, I know I'm not supposed to touch my face, but you know.
That's okay.
It only happens when you're on camera. And it is associated with two different things. One is trigeminal autonomic symptoms, meaning tearing on the same side of the headache. The eyes tear, they may become bloodshot. The patient can have a stuffy nose or a runny nose. They may have swelling of their eyelid or a droopy eyelid or just a sense of fullness in their ear. And then those can happen with migraine too. And they also get what's called a sense of restlessness or agitation. So most people with migraine, they want to, go down, lie down in a dark room, don't bother me, don't touch me, don't talk to me. People with cluster headache tend to want to move. They can't sit still. And even if they go and lie down, they often can't lie still. The duration is very typical. It lasts between 15 minutes and 3 hours untreated. And they tend to occur at very specific times of the day, which is unique to the individual. They can occur anywhere from 1 to 8 for every other day to 8 times a day. They last, weeks to months, and then they go away, right? The hard part is when people get this and they also have sensitivity to light, sensitivity to noise, sensitivity to smells, nausea, vomiting, food triggers. Okay, that kind of sounds like migraine, but you can have that along with cluster headache. In fact, you can even have aura with cluster headache. And so it becomes really difficult sometimes to figure out what's going on. And it's important to be able to make that distinction because cluster headache is approached completely differently than migraine is. And patients who have cluster who are treated like migraine or like they have migraine, they're not going to be very happy because the treatment's not going to work. So there's also a kind of a male preponderance to cluster headache. And so I think for a long time, women with cluster headache were sort of dismissed that you can't have cluster because that's a male headache. And that's not true at all. It's so slightly more common in men than women, but women can definitely get cluster headache. But there is no such thing as cluster migraine. You have one or you have the other. The hard part is thinking about cluster and making the diagnosis of cluster regardless of whether the patient has migraine symptoms or not. Okay, the migraine symptoms are sort of like extra, the extra you probably don't want, but they don't really figure into the diagnosis itself. So be wary about, could you have cluster? You were really diagnosed with migraine, but you feel like you want to kill yourself when you have headaches, you might have cluster, and they're always on the same side. The other ones are hemicrania continua and either high or low intracranial pressure. So I've missed the diagnosis of hemicrania continua as well. And I learned a lesson from that early in my career. So with hemicrania continua, you want to hear about a headache that's always on one side. It doesn't have to be the entire side of the head, even though it's called hemicrania, which means half the head, but it's always there. And it may be like so far in the background and so mild sometimes that people just don't even pay attention to it. But every so often it kind of rears its ugly head, no pun intended, maybe pun was intended, and the headache gets worse. And so it's still on the same side, but now it's more like migraine. Okay, so it's throbbing, it's pounding, it's severe with all those other symptoms that go along with migraine. And there may be autonomic symptoms as well. And so when people come in the office, often what they'll tell us is about their worst headaches, right? And they describe the headaches and the headaches sound like migraine. And they happen pretty frequently. So maybe they have chronic migraine. And what gets left out, unless we as providers ask for it often, is that, you know what, I'm never headache free. I always have a headache. There's always something back there. It's on the same side. It's like, okay, hemicrania continua. And again, the reason to make the distinction is because hemicrania continua is treated with indomethacin. It's a very specific treatment. It actually is part of making the diagnosis. And we would probably never pull indomethacin out of the hat for migraine until we were way down on the list of things that we would ever try. So keep that one in mind. And then the last one that I often see, and I'm going to mostly talk about low pressure because I think that is the one that's mistaken more frequently, is patients who get diagnosed with sort of intractable chronic migraine. And it turns out that they have a spinal fluid leak. So they're leaking spinal fluid from a tear or from an abnormal connection between a little cyst around one of the nerve roots as they come out of the spine. It's connected to a little vein and it's draining spinal fluid off out of the system. And so those patients often have headaches that sound very much like migraine. They often will involve the face as well, which is kind of unusual for migraine. The neck, the upper back, also a little unusual for migraine. The neck is not, but the upper back is. And they may have other symptoms, but the headache in general is pretty much constant, but it tends to get worse as the day progresses, the longer people are upright. And it also tends to be better in the beginning of the day when people first wake up, especially before they get out of bed. They may have a lot of other symptoms. This is sort of a long discussion to have, but they may have ringing in their ears or loss of hearing or balance problems or thinking and memory problems. They can have double vision. They can have other vision problems. They're just a whole host of things that go along with this. Not everybody gets everything. And the diagnosis can be really kind of tricky to make. And so it is determined by what we hear on the history. And the other thing that really clues me into this the patient potentially having this diagnosis is that they've tried everything. And, I see patients in my practice that by design, they have tough headaches to treat, and they've been around the block and they've seen a lot of people. And when people come in with a list of medications that's like yay long, which you probably am off the screen with my hands, that always makes me wonder, did we miss something? Because migraine usually responds to something, okay? Much more often than not, migraine is very treatable. So when migraine, can't be controlled, it always kind of makes the internal wheels start turning in my head saying, what do we miss? Did we ask the right questions? Has anybody ever asked the right questions? And have we asked them in a way that people really are thinking about their symptoms and can articulate what's going on? And so sometimes when I see people and I'm suspicious, I will actually give them stuff to read. So take this home, read it and think about it, and come back and tell me if you think this is you, okay? Because the only person that knows what's going on in their head is the individual person, okay?
Right.
And a lot of times the imaging is normal for this diagnosis, so it can be really hard to diagnose. And on the flip side, there's patients who have high pressure or pseudotumor cerebri or idiopathic intracranial hypertension. So we got a lot of names for that diagnosis too, all of which are legitimate. But these are patients that for some reason they're making spinal fluid, but they're not absorbing spinal fluid quickly enough. And so their spinal fluid pressure becomes too high. And these headaches can also sound like migraine. And interestingly, people who have this disorder are much more likely to have a previous history of migraine than in the general population. And we did a large clinical trial with pseudotumor or IIH, and we asked about a history of migraine. Over 40% of people said, yeah, I have a history of migraine. And in the general population, you would expect that to be, it's mostly women's disease, 18%. So I don't know if there's something about having migraine that makes people either more susceptible to getting this or more likely that once their pressure in their brain is controlled, they continue to have headaches because maybe their brain has already been sensitized for having pain. Now, when we make this disorder, there are a lot of things we like to hear about, and there are a lot of things we like to see on the exam. We like to see that the optic nerves are swollen. We like to hear about whooshing sounds in the head and times when the vision goes out, just briefly. Usually this occurs in younger women, under age 45 anyway, who are overweight, who have had a recent change in weight, or sometimes we find medications that cause it. But it also can be kind of challenging to diagnose as well, and it can be challenging to treat. So many times, we'll find that the pressure is high, and then we'll address it, but people keep having headaches. But, it's one of those other things that drugs don't really work if you don't make the correct diagnosis for.
Right. Interesting. That's just so much information. I get in a ton of questions in just so you know about this, which is great because obviously you're really hitting home to people. So we appreciate that. So here's a couple of questions about that. And you kind of mentioned it, but with the low pressure headaches, is there any way to diagnose that other than history? Does it ever show up on an MRI, like a standard MRI? Or is it just a history thing?
No, it's not just a history. For the people I see, it's just a history. I think it's they get weeded out because their MRI is normal. But about 75% of people will have a normal brain MRI, an abnormal brain MRI. And this needs to be done with contrast. And what we're looking for is that the brain kind of sinks a little bit into the skull. And so there are changes related to that we'll see on the MRI, particularly when we look at the side views. And the other thing that can happen is when you get the intravenous contrast dye in this condition, the lining around the brain, the meninges will light up, they'll turn bright, and they'll be thickened with the contrast dye. And unless you have contrast, we can't see that. So 75% of the time, we're golden. We look at the brain imaging, we make the diagnosis, and everything's fine. But then there's the other 25% of people that have normal imaging, okay? And the longer you've had the disorder, the more likely it is that you're going to have normal imaging. And from there, we would try to, do a blood patch, or we would try to find the site of the leak. But again, for that 25%, again, my practice is totally biased, because I, require that people have seen it under the neurologist first. So if their MRI with the brain was abnormal, chances are somebody figured it out before they got sent to me. And I readily admit that. But for the people that have a normal MRI, then we rely a lot on the history.
Wow, that's really interesting. 25% is a lot.
It is a lot.
Yeah, that's a quarter of the people who have it who it doesn't
I'll
show.
say that, with the flip side, if somebody asks that question about high pressure, it's the same story, right? So the MRI is not always abnormal with high pressure either. There are usually some subtle signs that we can find that give us a clue that's what we're dealing with, but not always.
That's really
So
interesting.
we rely not just on the history, but also the exam. We have criteria
Right.
to make the diagnosis.
So frustrating, but that's why we need experts like you who are just obviously interested in this area. And, I love the fact that you don't give up on patients, that instead of saying, well, it's just all in your mind, or you're not trying hard enough, which we hear, most people who have,
I know you do.
hear this, to have you say, well, did we miss something? That's a huge question, and it completely changes the whole atmosphere of how we approach it. And I think it can change the way that as patients, we're able to manage the disease, because when we don't feel believed, then we become less inclined to really focus on getting treatment, right? But when we are believed, then we become much more proactive. So that's huge. And so thank you for your interest in this. This is such a huge thing and really encouraging as well. So a couple of other questions about that. I know for one of the conditions, you went over several of them. I'm not sure if it was the hemicrania continua, where you said that there's often like facial pain with that, but generally there isn't with the
Low pressure.
It's the low pressure?
Low pressure. You can often get facial pain with it.
So would people would just have regular migraine? Sorry, I shouldn't use the term regular migraine here. Am I using a confusing term? People who have migraine, do they get facial pain? We had a question about that. Is it normal to have facial pain? Is it just an optional symptom some people have?
I would opt for it if it was up to me. But anyway, yes. People with migraine can get facial pain. They can get dental pain. People with cluster often get dental pain as well. It can happen. It's just not the typical story that we hear. Okay. I wouldn't discount the diagnosis if everything else sounded typical for migraine, and somebody had facial pain. We hear that from time to time. It's just not very common. So again, it's just one of those things that makes me wonder, like, am I on the right track here or not?
Right, something else going on or not. And I'm not sure how relevant this is to it, but we had a question about would a CT scan show pseudotumor, I don't know if I'm pronouncing this right, cerebri? Okay.
An MRI is much better. If for some reason you can't have an MRI, then we would do a CT scan with contrast. But an MRI really gives much better views. And one of the things we're looking for is the side view. So both for low pressure and high pressure, the view from the side is really helpful. And with CT, they have to reformat that. They don't directly image from the side. With MRI, the images are directly made from the side. And so we get really detailed views. And we're looking at the base of the brain where the pituitary gland lives. With high pressure, we want to see that the pituitary gland is kind of mushed down against the base of the brain, which is called an empty cella. And with low pressure, the pituitary gland is often enlarged, sometimes mistaken for a pituitary tumor when there is no pituitary tumor. And there are other things that we're looking for, but an MRI really shows the areas of interest that we're looking at much better.
Sure. So I have a question here where someone's asking about specifically, I mean, this could be relevant to any autoimmune disease, but they're asking about hypermobile Ehlers-Danlos, I presume. Are people with this or with other specific like comorbid autoimmune diseases more likely to have one of these alternative diagnoses versus migraine, or is there just no link that we know about right now?
So Ehlers-Danlos is a connective tissue disorder. And most people with Ehlers-Danlos do have joint hypermobility. They may have skin laxity, like they'll pull on their skin and it all just kind of pulls out like it's really elastic. They may have cardiac problems. There are a lot of things that go hand in hand with having Ehlers-Danlos syndrome. So POTS, postural orthostatic tachycardia syndrome, kind of goes along with it. And there are a few other things that for some people, again, kind of go hand in hand. But people with Ehlers-Danlos and joint hypermobility tend to be at more risk for having a CSF leak in their spine, for having low pressure headaches. And so, that's just one of the things to keep in your mind that can happen. But, that said, there is a very high coexistence of headache with Ehlers-Danlos syndrome, not related to low pressure headache.
Okay.
So again, it kind of gets confusing sometimes.
Right. No, that makes sense. It goes both ways. I really wanted to get into ocular migraine, which I know is not a term, but since you mentioned it, I know I have questions about it. But before I do that, we had a question about someone who said that just the back of the head feels kind of bruised. Is that more likely to be migraine, or probably not cluster, right? But could it be one of these other types of headache disorders, or is that just too vague a thing?
It's kind of too vague of a thing.
Yeah.
Low pressure tends to be in the back of the head. It doesn't have to be, but neck problems can cause pain like that. Occipital neuralgia can cause pain like that. There's a whole host of things that can cause pain in the back of the head.
Sure.
And yeah, migraine can cause pain in the back of the head too.
Right. No, that makes sense. Is it possible to have a CSF leak for, several years, decades even, and it not be caught?
Absolutely. Many decades. The world's record that I know of comes from Linda Gray at Duke University. And her record is 70 years. It was a man who had it when he was a child. He was never diagnosed till he was in his 70s.
Oh my goodness.
And yes, I see this a lot.
That's really sad that it's so common. And hopefully, we can figure out a way to have that diagnosed quicker going forward.
I would like to send you, if anybody thinks you have this, which I was thinking about this when I was getting ready for the call, saying I really need to beef up my website. But in the meantime, there's an organization that's called the Spinal CSF Leak Foundation. And they have a great website. I invite you, if you think you may have some of the symptoms of this, to take a look at their website, Spinal CSF Leak Foundation.
That sounds great. Maybe one of the admins who is on this right now can take a quick look at that and just post the link. Otherwise, I will do it at the end. But thank you. That's a really great resource. Switching really slightly, because I don't think you mentioned this unless I missed it, new daily persistent headache. Where does that fit into all these different diagnoses?
It fits into all of them, actually. It's a cluster.
Okay.
So new daily persistent headache is sort of this umbrella term that, again, it's a real diagnosis, but it doesn't really help us all that much. So it means that you never had a headache, and one day out of the clear blue sky, you developed this headache and it never went away. So high pressure, high spinal fluid pressure, low spinal fluid pressure, new daily persistent headache, hemicrania continua are all causes of new daily persistent headache. And so for new daily persistent headache, the first thing we do is make sure there's no secondary cause. So everybody gets an MRI, right? And we really look for other things that cause it. And about half the time we find a secondary cause. And unfortunately, the other half of the time we don't find a secondary cause. And it is a real bear to try to treat new daily persistent headache. If any of you guys out there have it, you know what I mean. We as headache specialists, we try to run towards the door when we hear that we're going to see somebody with new daily persistent headache, but hopefully we run towards the exam room instead. But
thank you for that confession.
Very difficult to treat NDPH.
Right.
But all of those things are all causes of it.
Right. And I think it's very easy, as patients, for us we get very frustrated when we can't find a good diagnosis. And so it's easy for us to get frustrated at our doctors, but we forget that, it can be really frustrating for you as well, because we're still missing so many answers. So that's just a reminder for us just to kind of really make sure that we work with our doctor and don't give up too
It's
quickly.
really tough when you're at the end of the line too.
Yes,
Because of my practice,
absolutely.
people have seen they're usually other neurologists, right? And so they've been dealing with this for a long time, and I'm brand new on the scene, and they're like ready to give up. I'm like, give me a chance. You just walked into my office, right? I mean, it's new to
Right.
me. It's not new to them. I understand that.
Right. No, I get that. I know when I see a new headache specialist, I don't want to answer all the basic questions, but it's easy to forget, it may not be new to me, but I am new to them. So just having patience and starting over again. And yeah, you see patients who are at the end of the line, which presents a whole load of new challenges for you, but hopefully it's also exciting for you because you get to explore, these things that a lot of other doctors don't go into. So
It's, I enjoy it. And most of our patients get better. So it's all good.
That's wonderful. A quick question about CSF leaks. A couple of people are asking, what can actually cause a CSF leak? For example, can having an epidural when you give birth to a child, can herniated discs do it? Or what is the most common causes? Or do we even know what the most common causes are?
I didn't plant that question. So, absolutely. Okay, so it's
people are looking on your website, so they know what you.
Oh, okay. They they're testing me. It's okay. So it's called spontaneous intracranial hypotension, but a lot of the things that we see, they're not so spontaneous. Epidural anesthesia, oh yeah. So, when they go in, then there was this great big catheter. It is a pretty large catheter. To do epidural anesthesia, it's called a TUI needle, and it's kind of got a curve to it. And so when the anesthesiologist goes in, they don't want to go through the dura. They want to go outside the membrane, outside the dura, into what's called the epidural space, right? That's why it's called epidural anesthesia. Right. So, but sometimes, oops, accidents happen, right? And they nick the dura. And most of the time when that happens, I think, the woman knows right away that something went wrong, because having a spinal headache is a really horrible experience. And so they'll go in and do a blood patch. But sometimes the headache doesn't start until after the woman leaves the hospital. Right. And so, a week later, a month later, maybe she was lifting the baby or something, and it just was enough to tip her over the edge, and this thing started leaking. And so, I've seen people that 20 years down the road after their delivery, that's probably what caused it. So anything that involves sticking a needle into one's lower back, including a spinal tap, a myelogram, even epidural steroid injections, right, and facet blocks, okay, they're not supposed to go through the dura, but sometimes things happen, right? So sometimes they do. Any kind of trauma to the back that you can think of, which includes surgical trauma. So, after having a laminectomy or a fusion, it can happen. After having a car accident, if you happen to have joint hypermobility and you kind of overdid it, so playing tennis, playing things that involve twisting, usually tennis, golf, kayaking, fly fishing, what did I say? What else have I heard? Lifting really heavy weights, often like a change in the exercise routine. Linda Gray talks about doing burpees. I haven't seen it after doing burpees yet, but she says they're bad for you because she saw somebody that had a CSF leak. Sometimes it's just like trivial trauma. We would never even think twice about it, like picking up the suitcase, putting it on the overhead rack on the plane. Hopefully someday we'll get to do that again. Minor stuff that you really wouldn't think much about sometimes can precipitate this. So, I ask a lot of questions in my office about, like, did you just move? Like, did you lift furniture? Did you pack a bunch of boxes and lift them? Was there anything that was different before all this started? And sometimes we find that there is some precipitating event, but often we don't.
Right. Interesting. And of course, of special interest to me is the steroid epidurals that people have, just because I have them. I have kind of a messed up spine. You only mentioned, like, if you have those into your lumbar back, but does it also happen?
Oh, no, anywhere.
Anywhere, right in your spine. Right. So if you have that and all of a sudden there's a change in a headache or something, then basically that's something you should look into and just.
Exactly. I saw a person once that She had an epidural injection in her neck, like, 2 days before. And then she couldn't stand up after that because every time she stood up, her head started killing her. And, I contacted the person who did the procedure who's like, no way. No, I didn't do that. No way. I'm like, "Oh, yes way." So
Right.
what can I say? Nobody wants to think
Interesting.
that they did something bad. I get that too.
No. Yeah, I mean, and we get it. Obviously, things happen. No one's perfect, but I think it's better to know than not. And generally, just for me, I think what I would say to people is that if you have a new symptom that's like that, then go see your doctor. Don't just ignore it. Follow up on it.
Yeah. Another thing that I would like to add to the list is chiropractic manipulation, especially if you have joint hypermobility, and especially in the neck. So I have no bad words to say about chiropractors. They do a lot of great things. I would just really avoid neck manipulation because really bad things can occasionally happen when that is performed,
Right.
including stroke, including blindness.
Wow.
So
That's really interesting and obviously very concerning as well. So moving slightly over, I know we're kind of getting short on time. If anybody has questions that are slightly different, just let us know things we haven't already covered. We're going to go for about another 5 minutes just to let people know. But Dr. Friedman has offered to do another session if we need to, if we have enough questions. I see you smiling about that, but I mean, not right away, but definitely that. So just don't give up if your question hasn't been answered, but we're trying to get to as many of them as possible. So you mentioned the terms ocular migraine, retinal migraine, eye migraine. This is, from what you said, this is just not a diagnosis. Is it just referring to a migraine that does not include pain and nausea? I mean, what is that? What are people?
there are a couple of ways, I'm sorry to interrupt. There are a couple of ways this term is used. By the way, retinal migraine is a real term. So people sometimes use ocular migraine, meaning their headache is centered around their eye. Okay, well, that's the most common place for a headache to be, actually, is up in the front. So that's not ocular migraine. And it's very common for head pain to get referred to the eye area. So a lot of people will go to their ophthalmologist first when they start getting headaches because they think they're coming from the eyes, when it's just that's where the pain is being referred to. The other is migraine aura without headache. So these are people that are getting typical migraine aura, flashing lights, zigzag lines, et cetera, and they don't have headache. So somehow that gets called ocular migraine. There really is, so that's migraine aura without headache. It's not coming from the eye, it's coming from the brain.
Okay.
The other term is retinal migraine, which is probably the closest thing to what you could imagine ocular migraine being. And retinal migraine comes only from one eye. So you have to really be sure that whatever the symptom is, which could be seeing sparkles or usually it's not zigzag lines when it comes from the eye, that's a brain thing. But if you're seeing flashes or, floaters or sparkles or whatever, and you cover one eye, you cover the other eye, and you are positive it's only coming from one eye, then that could be retinal migraine. You can also lose vision with retinal migraine. So all or part of your vision, again, only in one eye. So one way to figure this out is to cover one eye, cover the other eye when it happens and see if you can figure it out. The other way is to, for people that lose half their vision, because this is confusing too. Sometimes people with migraine with aura will just, half of their vision will just go away. And so they think it's coming from the eye that's on that side. And it's not, it's coming from the brain. So the other question I'll ask is, when you have this and you look straight ahead, what do you see or what don't you see? And if when you focus straight ahead, the entire half of the world is missing, that's not coming from your eye, that's coming from your brain. Right. And think about it, you can look straight ahead and cover one eye, you don't lose half of your world, right? Because the visual field of one eye overlaps with the visual field of the other eye. So they're just, sometimes it can be really difficult to determine where these symptoms are arising. But to have retinal migraine is actually very rare. It's a very uncommon condition. And most people that are having visual disturbance, in fact, they are truly migraine aura that come from the brain.
Interesting. That's really interesting. I actually have a member of my family, not going to say who they are, but they were diagnosed with retinal migraine and rarely get any pain. They could be driving and all of a sudden they lose vision in one eye. It just goes. And that was kind of like my introduction to it. You know, what on earth is going on? It's kind of interesting, kind of scary, I guess, as well, because it can happen.
Can be, for sure.
Yeah, definitely. So I do see some other questions here, but I think we're going to kind of bring it to a close for today because we've been going almost 45 minutes. Is there anything that, like, last closing words or thoughts you'd like to give for people before we sign off?
I just really want to, again, say thank you. It has been a privilege, and I hope that, you know, I've been able to answer some questions and help some people out and maybe get you to think about your symptoms and talk to your doctor about whether maybe this can be something else other than migraine.
Absolutely. Well, thank you. Thank you so much for being here with us again. Really appreciate it. You know, I think we met about 1.5 years ago in Baltimore at a Healthy Women conference. I was so impressed by you. And plus you're just a fabulous public speaker and great sense of humor, which never harms at all. So I'm really excited we got to do this, figured out technology. We actually didn't freeze the whole time, which is amazing. So I think that's kind of a miracle. We just got to take that just to say miracles do happen. Very excited to have you here today. If people do have other questions, please just post them in the comments. We'll try to get to them. If we have enough, then maybe we can convince Dr. Friedman to come back. But for right now, we're going to sign off and just wish everybody a good day. Please talk to your doctor if you have any of these symptoms. And just goodbye and thank you for being here and watching.